Let us begin this session with a case presentation. A 58-year-old woman presents to your office complaining of several little lumps in her neck. She has a history of long-standing diffuse goitres, but her history is otherwise unremarkable. And a physical examination is significant for irregular enlargement of her thyroid, and you note there is no cervical lymphadenopathy. You decide to check her thyroid hormone and TSH levels, and you order an ultrasound of the thyroid as well as fine needle aspiration biopsy to rule out carcinoma of the thyroid. Now let us discuss about the disease, which is multinodular goitre. So what is a etiology of multinodular goitre? It usually develops from long-standing simple goitres, which can arise maybe because of iodine deficiency or by intake of goitrogens like calcium and fluorides, or by means of thyroid hormone biosynthetic enzyme deficiency. So here, before discussing in detail about multinodular goitre, let us discuss about various causes of thyroid nodules over here. There are like benign as well as malignant, what you can see in this table. If you see the benign one, multinodular goitre, which is sporadic, which is also called as colloid adenoma, Hashimoto's thyroiditis, which is like a chronic lymphocytic thyroiditis, or cysts, which may be colloid, simple or hemorrhagic, and follicular adenomas like macrofollicular adenoma, microfollicular adenoma, and Hurtley cell, which is also called as oxyphil cell adenomas, and macro or microfollicular patterns. All these comes under benign. And if you see the next one, which is malignant, like papillary carcinoma, follicular carcinoma, minimally or widely invasive type of carcinoma, Hurtley cell type, medullary carcinoma, anaplastic carcinoma, and primary thyroid lymphoma, and at last is the metastatic carcinoma of the thyroid, and the breast and renal and other malignant neoplasms which spread to the thyroid can also be responsible for the development of thyroid nodules. And other factors which are associated with an increased risk of thyroid nodules and goitre are as follows. The first line in this is the smoking, especially in the areas of mild iodine deficiency. Alcohol consumption is also associated with thyroid enlargement, which is more commonly in women. And if you see insulin-like growth factor 1, the levels of this IGF-1, which are associated with thyroid nodules in the men as well as goitre in both men as well as women. And uterine fibroids also plays a predominant role in the development of thyroid nodules, like in one of the reports says that women with the fibroids had a twofold increased risk of thyroid nodules compared to the women with a normal uterus. And next is about the pathogenesis. It is mainly formed by the recurrent episodes of the goitre, or recurrent episodes of simple goitres, we can say. And if we talk about the pathology, in this we need to study about the gross as well as microscopic picture. So in the gross pathology, what you can see over here is a asymmetrical nodular enlargement of the thyroid, and in the microscopic picture you can see very clearly that there will be an individual nodules which shows a colloid rich follicles, and there also will be a follicular epithelial hyperplasia, and there are like areas of hemorrhage, calcification and fibrosis which are mainly seen due to long-standing pathological process. So this is what is about gross as well as microscopic picture. And what about the clinical manifestations, what we will see in this case? Especially in the goitre, the patients are usually euthyroid in state, but a few patients may present with hyperthyroidism, may see dysphagia, hoarseness. Is mainly because of the local compression of surrounding structures, more commonly the recurrent laryngeal nerve. And what is the treatment in this case? Synthetic levothyroxine is the treatment of choice because it especially suppresses TSH levels, which can cause like a decrease in the hyperplasia if the patient is euthyroid in state. And what are the important points for us to consider in this particular disease? The screening test is mainly done to assess thyroid function is the thyroid stimulating hormone. We know this. And a goiter can be toxic. In what conditions we will say that this particular goiter is toxic? If this goiter produces thyroid hormone, thus leading to hyperthyroidism, then we will call it as a toxic goiter. And it is non-toxic if it is not producing any thyroid hormone. And biopsy is mainly like FNA should be performed for any large irregular nodules, especially to rule out carcinoma of the thyroid. And what is the JOTS base dose effect in this case? Hyperthyroidism following intake of iodine in patients of endemic goiter, especially due to excessive thyroid hormone synthesis following exposure to the iodine, is called as JOS base dose effect. By this we completed the multinodular goiter.